This is Andy Principe again with Starling, and I wanted to remind you folks that you have the full faculty here from Starling of myself, Amanda, and Samantha on the line. And feel free as throughout the course of this learning collaborative to reach out to us if you have questions or comments or just anything that you want to discuss about the materials and the learnings. I'm going to move ahead. And today we're going to be discussing, as I mentioned, the framework for understanding and using risk in practice, which will tee up the third session's conversation about some of the kind of cutting edge uses of this framework to actually impact care in organizations such as yours. It sounds like some folks are having trouble hearing. AJ, can you hear any better at this point?
Yeah, I hear everything fine. I just want to make sure everyone else on the line is okay with it.
Okay. Also, next, a couple things happen after our third session. One is that we will be setting up one-on-one phone calls between the Starling team and your team to talk about the group project. We don't want anybody getting too worried about the group project. It really shouldn't be a huge time commitment for you. It's just an opportunity to reflect on some of the learnings, but we find that it's helpful to touch base kind of one-on-one, talk a little bit about your unique situation, how you hope to put the information in practice. So that's one thing that'll occur after our third session. The other thing that occurs during our third session is that we will be providing you with a case study, which if folks are familiar with kind of case study learning in business schools or the like, is essentially a written document that we're going to ask you to review and come prepared to discuss in our fourth session. And our fourth session will focus on analyzing that case study. And then our final two sessions will focus on the finances of risk and then a discussion that will be facilitated by you folks that will entail presenting out on the group project. Today's discussion, we're going to start by quickly going through some of your thoughts on the homework from session one. I've got some reflections on what you guys submitted, and I want to just kind of talk through those. Then I'm going to present you with our framework, and we break our framework into three different sets of skills, all related to risk, that include risk adjustment, risk stratification, and risk management. And understanding each of them and the differences between them is critically important. We're going to then look at some of the basics of risk scoring, and then we'll talk a little bit about your homework for session three. Hopefully nobody found the homework to be too intensive. Like I mentioned, we really try to just get you guys thinking about this stuff, spending a little bit of time offline without asking you to do anything too intense. I will say we had one standout, though, that actually submitted a really nice PowerPoint. I did not include their slides. I didn't follow up to ask if they were okay with that, but I'll kind of reflect on them as we go. And our first finding from the homework is not surprising. And really, it broke out that more than half of the group uses risk data minimally or not at all within their organization. Some were able to give some basic examples of how their organization thinks about risk. And a little less than half, 3 out of the 8 that responded indicated that they do get some information from either Medicaid or managed care plans to assist them in meeting the needs of complex patients. One of the things I liked about the more comprehensive response, the folks that submitted a PowerPoint, is that they actually took our value equation and indicated that in their current world, it's really a narrower view of that value equation. It was outcomes, specifically in their case as an FQHC UDS measures, and their cost. And they had a pretty good understanding of their cost. But risk as well as external costs really don't factor in yet to their equation as maybe it could or should. And that's certainly something that we think anyone going through a shift or a move in the direction of value-based contracting, that's kind of a key finding we want to understand. Is that without starting to take into consideration those additional elements, it's hard to fully describe and understand the value that you provide to those who pay you. The next question revolved around priorities for learning. And I wanted to kind of break these out so that we could kind of make sure that we're identifying opportunities to address each of them. So the biggest and most commonly mentioned was how do you establish a business model for taking on risk? So very specifically, how does risk link to payment models? And we know that this is a force that's pushing on us all the time, even when we are not changing essentially our payment and payment models. But in the sense that we know what it feels like to have a complex patient versus a less complex patient, and the impact that it can have on staffing requirements and time requirements and the like. So that's a major consideration, one that we intend to start addressing actually in our material today. The next was understanding the impact of social determinants of health and how to address these. And this is a very timely topic. It's something that's being very actively discussed. The CMS Innovation Institute has it's closed now, but had a significant funding opportunity around studying and evaluating the impact of social determinants as well as the ability to address social determinants on healthcare cost and outcomes. So that was a clear indication that risk is not limited to clinical risk or disease-based risk, but also includes factors of social acuity. And so you guys indicated that there is, in fact, a need to look at this and have a strategy for how to address this, and we will talk to that. The third was identifying risk screening or stratification tools that work well in our environment, and I think next week's session is really going to drill down on that. We'll talk a little bit. We'll actually present a couple of those today, just kind of from an overview standpoint, but in our next session, not next week, but next session, we'll be digging deeper into that and applying the right level of intensity to the right groups of people. And that's the process that we refer to and we'll be defining in greater detail as risk stratification, is frankly placing patients into different tracks of intensity based on the amount of risk that they present. Any others that folks want to add? I tried to do a high-level summary that kind of crossed multiple organizations' responses, but anything that I missed that folks want to make sure we know about? Okay. Well, I know when it's Amanda's turn to present in a future session, I know that she's pretty good at calling on people directly. So maybe I'll take a cue from that book at some point today. Let's see. In terms of the final question, what were the skills that you hoped to acquire in a learning environment? The first was how to go about contracting for risk, and of course this makes a lot of sense and will be a theme that we discuss throughout the process. The second is very much related. How do we build the capacity we would need ahead of contracting? So what can we be doing now that moves us in the direction of being better able to manage under some type of at-risk or risk-based contracting? And then the third is this demonstrating the level of risk in our population to our payers. And I think that's a very important topic. And one that I hit on last time is that we are in a stronger negotiating position. We're in a stronger position to take on the type of payments or the type of payment methodologies that we want if we can articulate the underlying risk factors in the population that we serve and really look to partner with those who pay us to come up with solutions that actually allow us to address not just the health conditions that face our population, but the risk factors that prevent them from achieving the wellness that they would desire to reach. So that was the homework. Just a couple of reminders as I get into the content. This is going to be a content-heavy session, and so feel free. The easiest way to ask a question or get something clarified is through the chat system, and so please feel free to chat a question or a comment, or if something doesn't make sense. The line is also open. While it's great if you could stay on mute, don't hesitate to unmute yourself if you do just want to ask a question. And with that, I'm going to transition to discussing a framework for better using risk in our environment. So you guys really kind of hit, I think, on the head why this topic is important in the responses to your homework. And so I'm going to lay out for you now some of the key questions that we should be thinking about as we discuss the framework for approaching risk in our environment. First is, how does the concept of risk impact safety net providers now? And it's already there. This is not a force that suddenly gets added to the equation. It already exists, and I think for those of you on an encounter-based payment system, you know that you have to be able to produce a certain number of encounters, essentially, to keep the organization functioning financially from a healthy standpoint. And having a blend of complex patients and less complex patients is actually almost essential to making that happen, because complex patients take up more resources and require more time, and from a provider's perspective, can very basically kind of mess up their day, change their day, so that they suddenly find that they're spending an hour with one patient at the expense of other patients. So risk is all around us, and it's already impacting essentially how we operate. We're also going to talk about how risk very much impacts how much our payers get paid, and then ultimately how much money they have to interact and work with us. We want to talk about how that impact essentially changes or becomes more important as we make the transition to value-based payments. We want to talk about how organizations are using risk information to improve outcomes, to actually find better solutions for individual patients. We need to know what is the data and information that we need to make this work. And I would say that that's a big part of our current practice, is helping organizations understand what information do they have now that can help them on this journey, and what information do they need to prioritize either building or contracting for in order to allow them to better manage their patients. And lastly is the kind of existential question. What's going to be expected of us? What's expected of us now? What's going to be expected of us? And how do we articulate that really from a standpoint of the value equation or a similar framework back to our payers? Moving ahead, let's talk a little bit about why risk matters. So, as I think everyone who's been in this business for any period of time understands, there's a national discussion really that revolves around American healthcare, and in particular, the various elements of cost in the healthcare system. Overall expenditure is growing. Expenditure is growing as a portion of our GDP. We have healthcare as a segment grows faster than inflation. I mean, there's a lot of different ways of saying this, but it's become a very important debate as to how do we rein in costs. And the reality of the situation is that there are a variety of risk factors that we can in fact impact and we can in fact control. For example, the very commonly used indicator of success in treating people with diabetes is the average A1C score, and we know that things like diet, exercise, and better medication management can in fact control those risk factors better. And as a result, we may prevent downstream negative complications of that disease, such as renal failure or end-stage renal disease, which is a very, very high cost negative outcome. So that's a perfect example of understanding how an underlying risk factor can lead to a very high cost situation, and something that in theory we should be able to take action on in a very meaningful way. Other risk factors can't be controlled. Things like race and ethnicity, which play a role or have an impact essentially on a variety of health-related conditions. It's a known situation that African American males with diabetes are much more likely than non-African American males to experience renal failure when they have diabetes for a long time during their life. This actually gets expressed in one of the most commonly used laboratory tests for kidney function. There's actually a factor that you have to adjust by for African American males. So even though we cannot control that is in fact a risk factor, the patient is born with that characteristic, we can use that information to, for example, intervene potentially earlier in certain cases, and therefore also reduce the likelihood of an expensive and frankly non-positive experience outcome either. Dialysis is not a good patient experience, nor is it a good cost outcome for the system. Are there any questions or comments before I move into more detail on the framework itself? Okay. We want you to start to use within your vocabulary in talking about risk 3 separate concepts that we feel make up the spectrum of risk that you'll need to understand as a safety net provider. Risk adjustment determines essentially the total amount of money that's available to pay for care for a population of patients. It's kind of a step that's taken in determining financial targets under value-based payment models that are based on total cost of care. So when you hear a payer use the term risk adjusted, really more often than not, what they're talking about is how they set or allocated funds to an individual patient within a population of patients based on underlying risk factors. We can also risk adjust quality outcomes, and I gave you an example of that in our last session. But this is about using risk data essentially to do kind of apples-to-apples comparisons either on the likely financial cost of a patient or on the quality outcomes of a population of patients. Risk stratification is a much more discrete process that's really about using data and tools to identify which patients may require additional support to manage inherent risk factors or identify patients who might benefit most from additional supports. Very simply put, it's about putting individual patients into buckets which receive differentiated levels of intensity in the care that they receive based on the likelihood that added intensity of care will have a positive impact on cost and quality outcomes. This allows us to prioritize scarce resources, take care coordination, for example, to get the maximum benefit across the population. We're going to discuss how organizations are using that concept in practice. And then the risk management component is very simply what we do about it. So it is the individual pathways or the set of steps that we take to address an underlying set of risks. And so different patients in different risk stratification categories will likely receive different pathways of care that we like to have those rely heavily on evidence-based guidelines. It typically requires the use of fairly sophisticated analytics tools. It might often requires us to expand the care team and care coordination and other proactive interventions that are really targeted to populations of varying risk. And so we might have a protocol, for example, in my using my renal disease example, that any time a patient hits a certain lab value on a certain test, something gets triggered. They show up on a care coordinator's report. The care coordinator attempts to get them in for follow-up care with a specialist. The specialist and the physician may, and the primary care physician might, work on a joint care plan. Those are the types of risk management approaches that organizations are taking. So we're going to now take you through a series of learnings that focus on understanding how risk adjustment models can impact and to a greater extent will impact how much you get paid under value-based reimbursement. We then want to look at some practical strategies to how we will use risk stratification to allocate resources in a value-based payment environment. And then we want to evaluate and assess various capabilities in case management, disease management, and population health management, which are the three most commonly referenced approaches to risk management. And we'll talk a little bit about all three, how they differ, and how they're similar. Couple of points to make. Approaching risk and value-based payments, it really requires us to do a couple things. First is to understand whether a payer's cost and quality expectations have been properly adjusted for risk. So if you are considering a value-based payment model that has an element of total cost of care, are they predicting the costs based on appropriate risk factors in that underlying population? And have any outcome measures been adjusted to be realistic based on the underlying risk factors of a population? I'm going to give you a quick example of both. In situation 1A, the idea that total cost of care would be predicted based on the underlying risk factors of a population, it's important to understand whether the plan or payer that was doing that calculation understood aspects of that population. I will give you just a concrete example, but we generally find that patients who are have third-party insurance provided through an employer, are stably employed, and have stable housing tend to have much lower costs of care for the same set of diseases as patients that don't have those, are uninsured or have limited access to coverage for their care, may not have stable housing, may not have stable access to food. And so if the method by which the premiums have been set have not taken that into account, there could be a disparity essentially in the expectation. The outcome measures are very similar, and we often get asked when working with FQHCs that have a homeless program, what are realistic quality targets for a population that is, caring for a population of patients that's largely homeless? Much of our work revolves around stabilizing the healthcare needs of these folks. We often don't get to, given the urgent needs that we need to address, it's not always possible for us to really be focused quite as much as we'd like to be on kind of long-term improvements the same way you might with a different population. And the answer to that question is this is a very much emerging field. And so I don't know, we're not entirely sure of anyone that's really defined what is the expectation for varying or different types of populations. But that's the work that's ahead of us. And actually, we feel that the safety net is going to have to play an important role in helping to answer those questions. Then we want to look at developing and implementing an approach to place individual patients into risk stratification buckets and identify a plan that is then applied to manage the patients in each of that bucket. That's essentially the framework right there. So let's get started with risk adjustment. We've provided you with a referenced definition. And as we go through, we're going to look at that definition together. We will kind of editorialize on that. We'll make some modifications, in terms of how we tend to think about it. But this is according to one of the leading organizations of actuaries. And risk, in their mind, risk adjustment is an actuarial tool used to calibrate payments to health plans or other stakeholders based on the relative health of the at-risk population. In particular, if insurers are limited in the extent to which premiums can vary by health status or other factors that are associated with health spending, risk adjustment can help ensure that health plans are appropriately compensated for the risks they enroll. Okay, that's a fairly technical definition, but what I hope it starts to uncover for you is that within the insurance world, there's this whole set of processes that really focus on making sure that an individual patient insured within a population of patients has the appropriate amount of financial resources allocated to that patient based on the underlying risk factors for that patient. Why is this important to you as safety net providers? Because it starts to frame the fundamental challenge that the organizations that pay you face. They have limited financial resources. You become a key ally in essentially helping them manage those financial resources, and those financial resources are based on risk. So here's a scenario. Take, for example, a Medicaid managed care plan that contracts with your state to accept a capitated payment to provide a patient with a set of benefits for a 12-month year. For a healthy adult, an adult patient under 40 years of age, this payment may be as little as $600. And that has to essentially last the entire year, and it needs to cover the full scope of benefits for that patient. For an older patient with congestive heart failure and end-stage renal disease, this payment could be as high as $100,000 for the course of a year. So you can see that there are significant variations that are driven by certain risk factors. So given this wide discrepancy, the health plans have developed this capacity known as risk adjustment of premiums to more accurately predict the cost of a population. And what that gives them is some leg up in the negotiations with the state about how much they need to be paid to assume the financial risk for that population. As you can imagine, having a few more patients in the $100,000 category than anticipated can really sink the financial success of a plan. And if you as a provider ever consider operating under a financial model like capitation, you can certainly see how risk really becomes an important concept to understand. Here's two populations. We've tried to give you a little bit of clarity on how this might work, and we have come up with a completely hypothetical risk score of 1 through 7, 1 being low risk, 7 being the highest risk. And based on this population, I think you can pretty quickly come up with some interesting observations. Population 1 has quite a few more patients in the 4 and 5 and a lot less in the 1 and 2. Population 2 is a larger population, which looks like most of its patients really fall in the lower tiers of risk, the 1s and the 2s. But to really understand how this might play out, each risk score really needs to be essentially turned into an average cost. So if we took this average cost ranging from $600 to $50,000, you can see a plan could theoretically add up and reach essentially a total cost based on this weighted average method. And that's all this really is doing. So with 465 patients and a total predicted cost of about $1.4 million, each patient in this population would have an average predicted cost of about $3,000. Plan or population 2 with many, many more patients in the low risk group, while it has a much larger population, the actual total predicted cost would be much lower. And as a result, this population has an average predicted cost of less than half of the first population. So it's incredibly important whenever the passing of financial risk is occurring from one organization to another to understand the underlying risk of that population and to use tools such as risk adjustment to understand what the reality of the financial implications of sharing risk will be. Now, I want to, at this point, take a quick second to say we don't anticipate that safety net organizations are going to spend a lot of time risk adjusting, but we think it's a very important concept to understand because it has implications on any negotiations you might have with health plans. So the type of questions that you must be thinking about when discussing any type of value-based relationship with a health plan or with your state or really with whomever pays you is, did they take a meaningful and sound approach to identifying the risk factors in the population? Essentially, have they put the right patients in the right buckets? Are the premiums assigned to the buckets adequate? So is it realistic that they could manage a patient with only $600 if they were a level 1 risk? And does the bucket is the bucket that a patient is in tell us anything about how to manage that patient? I gave you a completely hypothetical risk adjustment example. I didn't tell you anything about risk level 1 or risk level 7. Just that we had predicted costs for each. This is the most complicated aspect of managing risk, and one that is oftentimes, I think, more confusing than helpful to providers when they're in discussions with those that pay them. So let's talk a little bit about kind of why these methods are limited, and then I'm going to talk a little bit about how, in theory, these scenarios kind of work somewhat to the safety net's disadvantage and how we can improve our skills in this area. First and foremost, evaluating the risk of an individual patient and then ultimately a population of patients is typically a defensive strategy on the part of the health insurer. So it's not necessarily done for the best interest of the providers in the network. It's not necessarily even done, for the benefit of the patients. It's truly about making sure that the insurance company receives enough money. It's important to understand that because when you get into conversations about how to better manage risk with your plans, oftentimes there'll be this question of should we use risk information that they share with us? And it's important to remember that since its purpose, it was that process that I just kind of, hypothetically walked you through is really about protecting their financial interests. It may not be the most useful information in terms of how to actually manage the patient. This practice of risk adjustment has been in place for decades, and it's evolved from a time before the widespread availability of electronic health records or health information exchanges. And whenever something is done essentially on the health plan side, it's almost always done, if not exclusively, then almost exclusively with paid claims data. And that can be very problematic because that may not be the most indicative of the actual health status of the patient. We also have the challenge of patients who may churn on and off, for example, Medicaid coverage, and so not all of their claims actually reached the plan, so they may not be looking at the whole picture. There's a lot of reasons why it can be problematic that we can't yet factor in EHR or health information exchange data. So risk models have really been optimized to be predictive of cost, and they're unable to take into consideration certain clinical and social factors such as precise level of chronic disease control or housing status as examples. These are opportunities that I feel the safety net has to kind of establish a leading position in helping better educate insurers, frankly, about what matters. What are the things that really drive financial and quality or outcome success within a population. I'm going to show you now, and again, this is the most technical stuff that we're going to cover in this entire series. But I want to show you the most widely used risk adjustment model. And my point in showing you this really does revolve around exposing some of the limitations of risk adjustment, helping you understand what pieces of the risk adjustment puzzle your organization actually does play, and also I think to give you a sense that payer-driven risk scores may not be your best strategy when it comes time to risk stratify your patient population. The CMS Hierarchical Condition Categories Model, or CMS HCC, is used by CMS to essentially allocate or identify essentially a predictive cost for a population of patients. And it takes into consideration 6 inputs. Some demographic information, disabled status known as OREC score, original reason for Medicare eligibility, poverty status, so if the patient is dually eligible, so eligible in addition for Medicaid, and then historical ICD-9 and ICD-10 codes. It has a model for looking at how certain ICD-9 and ICD-10 codes can interact with one another, known as comorbidities, and then interactions within those comorbidities. So, for example, hypertension or high blood pressure and diabetes have a different set of, present a different set of risks than diabetes without the presence of hypertension. So they plow through historical claims data, looking at the ICD-9 and ICD-10 codes, factoring in the other series of factors, and they take the roughly 70,000 ICD-10 codes down to about 95 HCC groups. You can't see it on the chart here, but when you get the slides, you'll be able to see that these HCC groups essentially group much larger numbers of diseases into common buckets essentially that drive cost and are predictive of cost. So then essentially each group has an associated capitated rate that is then adjusted based on age, gender, and other factors. So in my hypothetical example, I gave you a 1 through 7 scale. This scale has 95 different variants. And, just to give you an example, I know it's probably a little small to see, but there's a variety of ICD-9 codes that would lead to the grouping of a patient into the COPD risk grouper, and CMS has a pretty good handle on what it's going to cost to care for a Medicare beneficiary with COPD from a cost standpoint. But what we often get asked is, should we get the risk scores from our health plans and use those to model or drive care? And while we think that might be interesting information and potentially useful, knowing, for example, that a patient falls into HCC 81, which is myocardial infarction, probably doesn't give us information that our clinicians didn't already have. And despite knowing that that what conditions led to the CMS's ability to predict cost, we don't learn anything about historical care that has led to that cost from this risk scoring model. So we don't learn anything about whether the patient has been receiving appropriate care, whether they're followed by the right specialists, whether they're using the right medications, or whether they've had various surgeries. So not particularly helpful information for us. Incredibly valuable for CMS because they can predict their costs, but not very useful for us as providers. So can we use payer risk scores to improve costs and outcomes? It is our finding that they are generally inadequate to drive risk stratification and risk management programs. They're not particularly easy to understand, therefore they're not particularly usable by clinicians, essentially to vary care levels on their own. And they don't tell us enough about the underlying risk factors, such as barriers to better health. It's perfectly helpful or valuable to know that the patient's had a heart attack, but chances are your clinicians already know that. The question that really revolves around better managing risk usually revolve around, is the patient willing to be an active participant in changing their health outcomes? Are they willing to essentially, co-develop with their provider a treatment plan to get them to a better health status, and then can we get them the resources necessary to do that? Those are the types of things that typically drive change. I want to reflect on two important things that you should know about how the risk adjustment process presents some challenges and potential inequities to the safety net and to safety net providers. First, because there are minimal inputs associated with social determinants of health, it's often that populations of patients who are seen in the safety net setting appear to be of no greater risk or predicted cost. We hear sometimes that in kind of large studies, they don't find a significantly compelling difference in the overall risk between for example, an FQHC's patients and patients seen in another setting of care. But that's an easy statement to make when not including significant data on social determinants of health into that equation. This, again, represents an opportunity that the safety net as a whole, I believe, will need to take a leadership position on and assist in changing. But currently, those models have very limited ability to adjust for social determinants of health. And the second and more interesting is, AJ, I don't know. Looks like we're coming back. Sorry about that, folks. The second and also challenging is that sometimes our payment models in and of themselves have reduced the incentives to as thoroughly code ICD-9 and ICD-10 codes as possible. The example that I often use is one that I hear anecdotally when I spend time in clinics that have a PPS type payment system, which is that if the patient comes in for a sore throat, we might end up spending 45 minutes treating their other 5 chronic diseases, and the bill goes out with the code for sore throat because that's all we needed essentially to get paid. So we may, to a certain extent, be disadvantaging ourselves in what may be a simplistic way to get billed, to bill and get paid. We may have somewhat disadvantaged ourselves. So when you hear folks talk about the importance of really thorough ICD-10 coding, it's because those ICD-10 codes end up getting used in risk adjustment models that determine how much money is allocated for various patients. Not a lot of actionable information on risk adjustment. So what we wanted to do is provide you with a list of questions that we think are important to have a general understanding of when discussing value-based payment arrangements with payers. It's important, we believe, to have a general understanding of the methods that they use to risk adjust premiums, to understand how their premium levels impact financial targets, if there are financial targets in the value-based reimbursement, whether they use any social risk factors in their models and how they derive those factors, whether we would have the ability to access or understand their models, and whether we can see the score assigned to an individual patient. Again, that may not be the most useful information in terms of presenting it to a clinician to drive change, but understanding our relative risk load as assigned by the provider can be useful and valuable. Does their model suggest any action to be taken on a given patient with a given risk score? So if I told you that it was a HCC 81, is there an expectation that that person would receive or that patient would receive any particular care protocols that they find to be useful and effective? And how adequate are the premium payments per risk score? Do they feel as if they're actuarially sound? Are they anticipating that they should, in theory, be able to maintain margin by managing essentially the medical loss of the financial medical loss, essentially what they pay on claims? Again, this is the least actionable from a safety net provider standpoint aspect of the framework. So we wanted to give you some basic understanding and questions as to how to use this information. I'm about to move into risk stratification, which I think I hope to give you some comfort is much more actionable. Any questions before I do so? Okay. this is a definition of risk stratification that we like quite a bit. Put simply, to risk stratify patients is to sort them into high, moderate, and low health risk tiers. Risk stratification aligns the practice's very limited time and resources to prioritize the needs of its patient population. It can and should involve sophisticated algorithms and robust registries, but it relies just as much on patient experience and physician judgment. And that's an important point at the end, because I think one of the things that you'll find is that some of your best allies in determining how to stratify patients into risk scores are probably the people who care for them. They probably have a pretty good sense of which patients require a lot of intensity and which patients may require less intensity of care. Just to revisit, this is a little bit of repeat information, but in this transition, we thought it was important. We don't think it's simple enough to ask for your payer's risk score and then somehow use those to risk stratify patients. Our experience is that these scores can be helpful for a couple of things. One, it can allow us to do some population benchmarking. For example, to see the prevalence of various diseases as compared maybe to other populations. It helps create a starting point for negotiations of cost benchmarks for contracts that include things like shared savings or capitation, and it helps identify high-level staffing needs based on prevalence of disease. But what it doesn't do is it doesn't really provide us with the information we need upon which to base resource allocation decisions. There is a question. The question is, can we clarify the difference between risk adjustment and risk stratification? Don't you first need to stratify patients in order to adjust the cost of the population? So we are defining the distinction between adjustment and stratification as adjustment being the use of historical data really to drive the setting of premiums or financial resources. And so it's much more of an insurance-driven function. It does have implications on providers that wish to enter into value-based contracts, but it's not something that providers will typically do much with. They're not doing the risk adjustment. The risk stratification, as we'll discuss, is really focused on using historical data to put patients into actionable tracks of care. And so adjustment and stratification, we like to think of as almost being two sides of the same coin. One, the payer side, the other, the provider side. The payer's focus is very much around financial. The provider side really should be about aligning resources with need. I hope that's helped provide some clarity, and I think you'll see as we go through the definition. You don't need to, there was an inherent, if you want to use the term stratification, there was an inherent stratification that occurred in the risk adjustment process. But we're really talking about, from a provider's focus, taking patients and putting them into buckets that align with action. So many organizations that have used risk stratification successfully have focused on a much more pragmatic approach. First, developing and implementing a meaningful data-driven approach to stratifying patients, allowing for an override when factors that are not included in the risk model have had an impact on patient experience. So this is allowing essentially a provider or a physician to say, the data may show that this patient would be a low risk, but I happen to know that they've got a lot of stuff going on and probably need more intensity. And then clearly defines the risk management activities that are applied to each level of stratification. And we're going to take you through some concrete examples of this today. The data sets that are used in provider-led risk stratification include potentially claims and ICD-9 or ICD-10 history, but not all organizations have access to them. So we're looking now at models that can include EHR and clinical outcome data, demographics data, social determinants of health data, information about healthy behaviors, and data from various screening tools. And it can be very challenging. I happen to know that several of you on the call today are actually somewhere in trying to implement this. And I think you've started to understand the complexity and just how much information and data is out there to do this. Let's talk about some real models. So Mayo Clinic, I'm not sure for how long they've used this or if it's still kind of their most current thinking, but for a long time, simply looked at number of conditions, and they would take ICD-9 codes and they would break them down into what they call conditions, kind of like that HCC grouping that took 70,000 ICD-10 codes and got down to 95 conditions, and essentially said that here, 0 is those patients who have no chronic conditions. Basic is 1 to 3, intermediate 3 to 6, extended 7 to 9, and complex 10 plus. And in implementing this model, they didn't necessarily do a lot of differentiation between conditions. They just basically said that patients that have more conditions will likely require more management, greater intensity of management of resources. AFP, American Academy of Family Physicians, has proposed a four-level model, although there's actually sub-levels. Primary prevention is generally healthy patients with no chronic diseases, but could include patients with some risk factors for chronic diseases. And they would fall into a group they call primary prevention, really focusing their care on essentially maintaining that health status. The secondary prevention patients are kind of the activated chronic disease patients. They have chronic diseases, but they're meeting their management goals and have not developed complications. And those patients, really the focus might be moving them towards primary prevention wherever possible. But generally speaking, they receive some additional resource but are not considered to be the high-risk patients. The tertiary prevention are the high utilizers. They have high resource expenditures, or they have chronic diseases that essentially are unstable and as a result have had complications arise. These are the kind of the intensively managed chronic disease patients, and then their catastrophic level is essentially the super utilizers, maybe the top 10%, which really require pretty intense coordination across multiple subspecialties. And by putting patients or stratifying patients into these buckets, they can actually plan for the level of resources necessary to care for population. And that's going to be different for every population, as evidenced by these risk levels. The California Quality Collaborative has a risk scoring methodology that they utilize for all discharged patients from hospitals. And this, we wanted to provide a hospital example because this focuses on the intensity of telephonic and other care coordination they provide to patients at discharge. Every patient gets assigned a risk. A low-risk patient will receive a discharge assessment and a focus on improving one area of self-management. They follow up with the patient within 1 week and may continue a monthly follow-up if necessary or if risk changes. Whereas a mild risk patient will receive follow-up within 24 to 48 hours, then once a week until the risk has been essentially reduced. This is the population where they consider near immediate in-person follow-up in a primary care or community-based care setting. As they move into level 3, the intensity essentially grows in terms of the follow-up that they provide. They create a much more comprehensive action plan with that patient, and the primary care physician is engaged and involved essentially in the evaluation of that plan. And level 4 really involves the primary care physician almost on a weekly basis. So the level 4 would be the patients who would be absolutely most likely to end up back in the hospital. So it's valuable. It actually saves money to utilize primary care on a very intensive basis to try to keep them out of that unnecessary hospitalization. So in terms of thinking about how risk stratification might work in your care setting, We have found that simple, actionable, and easy to implement risk stratification models tend to work better than ones that try to be extraordinarily comprehensive. As you start thinking about a strategy, it's important to understand that while a factor might be important, if you don't capture it as discrete data, it's going to be very hard to use that in your risk stratification. If you capture it as discrete data, but it's not captured consistently, you're going to essentially have very little data to work with, and you're going to underestimate essentially the risk of a population. Data may not be captured in a timely fashion. A screening that was done 3 years ago may tell you very little about the patient's mental health status today. And the people executing your risk management approaches, which we'll talk about next, need to be able to find your stratification, they need to be able to apply it, and they need to be able to execute against it. So all of this suggests that the risk stratification and risk management processes are really very data and information systems intensive, and really, thus the big drive towards universal adoption of electronic health records over the last 15 to 20 years. Finally, I'm going to define for you risk management and take you through some examples. Are there any questions before I move forward? Okay, well, please feel free to send them in by chat if you do. So when we talk about risk, I'm going to move ahead. When we talk about risk management, there are three major categories. And so rather than defining risk management at the high level, we prefer to, to essentially define each of the three major strategies. Case management is a collaborative process of assessment, planning, facilitation, care coordination, evaluation, and advocacy for options and services to meet an individual and family's comprehensive health needs through communication and available resources to promote quality and cost-effective outcomes. Many of us are probably familiar with insurance-led case management initiatives where maybe they come in sometime during a patient's hospitalization and make some recommendations on how to essentially minimize costs and improve the likelihood of a good outcome. But case management is usually triggered by an event. So you case manage essentially a COPD hospitalization, or you case manage the contracting of a certain communicable disease, and you'll have essentially a set of pathways that the patient will go down once that triggering event has occurred. Disease management, on the other hand, is the set of activities aimed at improving the health and clinical outcomes of a population of patients defined by a chronic medical illness. So a little less episodic and really more based on the state of or the presence of a certain disease. So a diabetes disease management program will be essentially a set of evidence-based pathways and tools that are triggered by the patient having essentially a certain disease. And then the broader population health management is kind of the looking across the whole population, chronic disease or otherwise, and trying to analyze all of the entire population's data to pinpoint things that can be done essentially to improve the overall cost, overall outcome, and overall patient experience of that population. So it's a little bit of a broader concept that actually requires us to look beyond just those patients with chronic diseases. So it's formally defined as the aggregation of patient data across multiple health information technology resources and an analysis of that data into a single actionable patient record on a per patient basis, so that all providers within a coordinated system are working in the direction of clinical and financial outcomes for that population. Providers, and I think this actually answers some of the question about risk adjustment and risk stratification and how that transitions into risk management. But providers and payers look at this very differently, and it's important to understand that as you go forward. Excuse me, folks. So what I want to leave you with today as we move forward is that we are going to be focusing very specifically on how safety net providers can start to apply some of these principles in their practice ahead of maybe feeling an immediate need to be in value-based reimbursement models, so that they can most efficiently and effectively take action on the population of patients that's assigned to them. That's going to rely heavily on understanding ways of stratifying patients into different risk categories, and then developing and applying the appropriate risk management approaches, whether they be case management focused on very specific episodes, disease management focused on very specific disease states, or more broader population health management, which is really focused at understanding in real time kind of the health-related needs of the population. Specifically, we want to look at using resources to support implementation of a care plan that really helps our patients get to the balance of outcome, cost, and enhanced patient experience. And every one of your organization is going to need to do that somewhat differently. But of course, we can identify best practices and really work towards assisting one another in being successful in doing that. I'm going to, before I talk about your homework assignments, this is really meant to be a foundational learning module, because we're going to get into much greater detail on the specifics of using this framework. I want to pause and see if folks have any questions or comments or just general discussion that they'd like to have. A very quiet group. I think we'll probably have to work on finding some ways to get folks talking. I know that when we get to our case study, certainly you guys are going to be doing a much larger set of the discussion. Are any organizations, can I ask if any organizations are actively pursuing this, and kind of what have your findings been to date in terms of attempting to perform risk stratification or implement risk management approaches?
Hi, this is Sue with Family Healthcare in St. George, Utah.
Yeah, hi, how are you?
So maybe we're not asking questions because it's a lot of good information to process. But what I circled is really trying to figure out how to start using our data to really risk stratify. A few years ago, we went through the NCQA PCMH recognition process, and we were needing to identify high-risk populations in order to work at figuring out how to stratify them and or case manage them,
sure.
Right?
Sure.
But it really has become a challenge for us to figure out how to do that tightly enough to get a small enough group on certain areas to really know what to do with the information, like high utilizers that maybe have over 14 visits in a year, or
yep.
People who are disease managed by, they have hypertension out of control and A1C over 14 or over 13 or something like that. So anyway, I can certainly see where you're going, and it'll be interesting to begin to understand how to really put groups into the high, moderate, or low risk stratification. So
right.
Thanks for this, and it's just something I'll have to process a little bit. We have lots of data. It's just now, what do I do with it to really help us improve outcomes and reduce resources? Right.
And I think that what we've found is that at some point you do have to kind of cut and run. You can't, if a data set that you'd like to factor into a model just isn't available, certainly focus on strategies to start building it. but also focus on what can you do. So, in your example of the patient-centered medical home, how do you identifying high utilizers might, while you may love to have the actual claims data to be able to discreetly identify which patients utilize the most resources, using knowledge of the patient and the providers themselves to maybe do some of that as a proxy is a potential way to get started. A lot of early models, and I showed you the Mayo model. Really just look at how many diseases does a patient have, how many different ICD-9 codes have ever been used on that patient, as just a proxy. It's not perfect, but it's a pretty good proxy to get you started. And the models will grow in sophistication over time and will start to become, I think, more publicly available as more groups push in this general direction. As I mentioned, I know we have some groups that are actively engaged in this work right now, and so hopefully throughout the course of the remainder of the discussion, that'll really come out, and we can start to get to some of the early learnings based on their experience. Any other comments or questions? Okay. So actually our homework assignment, again, it shouldn't take you much more than 15 to 30 minutes, but we'd like to hear from you, and we'd specifically like to hear from you on where you are in this process. Specifically, if you are using a formal method currently to risk stratify patients, with which tools or methods are you using? Is it some type of screening tool that you've developed or adopted? Is it a score provided to you by the payer? Is it a score that you yourself calculate, or is it some type of subjective assessment? And how do you go about varying care coordination or other care resources based on that risk? And it's certainly okay if you're not doing that currently today, but this will give us some insight. It'll give us something to discuss in our next session, but it'll also give us some insight into where you guys are in the process, which really does help us on a week-to-week basis kind of make sure that we're honing in and focusing on the right areas of our discussion. You will complete this as well as a general survey about the education session using the link that AJ has provided. In addition, you'll be receiving a copy of the presentation material and I believe the recording as well. So you'll be able to reference back to the material should you need it. And do not hesitate. I've told you this a couple of times now. Don't hesitate to reach out to us should you have follow-on questions or need any clarification either on the homework or on the material in general. We're more than happy to address those questions for you. If there are no further discussion questions, I was going to turn it to AJ quickly. So let me stop. Are there any further discussion questions?
Hey, Andy, this is Aaron from Iowa, and you answered Megan's question earlier. And I think one of the reasons we're still kind of thinking about this a little bit is this kind of idea that you have two entities potentially doing hopefully similar but potentially different work. So you've got the adjustment being done by the payer, then you've got the risk stratification being done by the provider group. At some point, and I guess this is why you said these are a set of questions that you should ask the payer about how they do their own adjustments, because you need, at the same time, to align them to some degree, because you want to make sure that the higher resource availability is potentially connected to your risk stratification strategy, right?
Right.
So I guess,
let me give you kind of a really
question. We're just like toying with that in our minds.
No, but I appreciate the comment, and I'll just reflect kind of quickly on it. I'm going to give you like the dirty little secret of how all of this works in practice that I think is something that we need to up our game in order to address. So, in a let's use a managed care environment, which is where there's private insurance companies managing Medicaid dollars. As I think many of us know or have experienced, those contracts are awarded typically through an RFP process. Part of that process is the plans making claims about how little money they need, because the cost proposal is an important part of the process. So they want to bid low, and then when they go to if they win and they go to contract with the state, they may have a strategy, an internal strategy, to take a loss in the first year to win that contract. And so they're getting maybe less premium than what another plan might be getting, and now they've got to manage within that. And they want to control and minimize their losses. Well, if they come to a group of safety net providers and say, we want to give you a contract where we're going to share savings with you if you manage within the limited budget that we have, and it's already tilted because they've already accepted that in the first year they're going to take a loss, then we may be walking ourselves into a situation where it's it's almost impossible to come out on the right side or the successful side of that financial arrangement. So understanding what went into rate setting, understanding what went into the adjustment of premiums, we feel is very important. It's not necessarily a skill that you're going to replicate yourself, because it's built on these historic financial models that they've developed over the years. But understanding, do they understand? Do they really feel that those premiums are realistic? If they incentivize us based on achieving that, are we walking ourselves into something we shouldn't take? And of course, there's kind of a no downside arrangements, which say, okay, if we save money, we'll share with you, but if we lose money, we're not going to punish you financially. But certainly, if you think about taking any kind of risk that has kind of both sides of it, you really need to understand how they did what they did and why. So we think it's part of upping the game of the safety net in terms of how we go to contract, specifically as we start to transition to value-based payments. So thank you for your comment. Okay, AJ, I didn't know if you had anything that you wanted to add before we let the group go. Otherwise, we'll let them go a little bit early today.
Nope, I think that's everything. I'll follow up with all that material you mentioned in the next couple of days. So I think that's all.
All right, perfect. Thank you, everyone.